everyone, and welcome back to the Living Well with Schizophrenia YouTube channel. I'm really excited about today's episode because we're going to be talking with a psychiatrist who treats people who are living with schizophrenia and schizoaffective disorder. Her name is Monica Slubicki, and I'm really excited to hear her insights and her perspectives in terms of the relationship between somebody who's living with schizophrenia and their psychiatrist, and what the process of diagnosis looks like for someone who's living with schizophrenia, as well as what treatment options there are, and just kind of talking more about the psychiatrist-patient relationship as it pertains to those who are living with schizophrenia. So this interview is a part of a larger project that we're starting where we're interviewing different healthcare professionals such as psychiatric nurse practitioners, psychiatrists, psychologists, pharmacists, and so I'm really excited to speak with Monica today and hear her insights as a psychiatrist. But first, if you're new here, my name is Lauren and I make videos about what it's like living with schizophrenia or schizoaffective disorder. So make sure to subscribe to our channel so as not to miss any new exciting content like this video. Also, if you want to help support the creation of future videos like this one, please make sure to check out our Patreon page. The link is in the description below. We're really working hard to continue making valuable resources for you, our audience, and any support would be so appreciated. Thank you. Hi everyone, so today I'm joined with a psychiatrist from the United States. Her name is Monica Slubicki, and we are so excited to have her here. Hi Monica.
Hi.
Thank you so much for joining us.
I'm really excited.
Yeah, so we're going to be talking a little bit about kind of the process of making a diagnosis of schizophrenia or schizoaffective disorder and what it kind of entails from a psychiatrist's perspective. So, starting things off, what kind of early signs would merit seeking out opinion with a psychiatrist?
Well, I think, first of all, anybody who is experiencing anything that's not their typical emotions, mood, behavior, experiences, should talk to a mental health professional. And definitely if there's issues of safety, thoughts of harming yourself or other people, definitely reach out. But in terms of schizophrenia, schizoaffective disorder, and related disorders, there's a pretty well-established what we call a prodrome before the active illness, and that can last, generally it lasts a couple of years actually, and it's a very gradual thing. It's not present in every person, but many people experience it. And so it starts out with very non-specific things like depression, withdrawal. Oftentimes people will have problems in school or at work. And then it sort of gradually evolves into things that are more associated with psychotic disorders. So like unusual thinking, disturbances in perception, meaning hearing things that aren't there, seeing things that I'm not sure are there. And initially a person may have questions about if things are real a lot, sometimes if they're real. And then it sort of evolves over time where a person stops questioning that and kind of is more fully, might start having, real delusional thinking, which are fixed beliefs. And at that point, it's closer to the more active illness. So, anytime along the way, I think the important thing to note is that there's good evidence that says that intervention early on can improve the course of the illness and improve quality of life for people. So there's kind of a pretty big focus right now on getting people early help.
Yeah, so early intervention is definitely something that we're seeing a lot more of in terms of psychosis. And so I guess my next question was kind of like, what initial symptoms that a patient may be exhibiting would lead you to consider schizophrenia or schizoaffective disorder? But you kind of talked about that in terms of the symptoms that you described in the prodrome phase, as well as kind of the evolution of symptoms that would lead you to think about schizophrenia or schizoaffective disorder. But is there anything else that would maybe trigger thinking that could be a diagnosis for a patient?
Yeah, I think diagnosis these days is and has always been complicated in psychiatry. And so, and our categories are very fluid in a way and evolving, and there's spectrums of things. But I think when, there's sort of persistently what other people would say are bizarre or unusual beliefs, and schizophrenia, schizoaffective disorder, in addition to this sort of characteristic hallucinations, delusions, which most people think about, there's also disorganization, which is another part of psychosis. So disorganized thinking, which leads to disorganized speech. There can be disorganized behavior, like people make with odd posturing and that kind of thing, although that can be seen in other illnesses too. And then there's cognitive symptoms in schizophrenia, and I think, again, also associated with other illnesses, but it's something that if a person comes with this constellation of things, then you start thinking about that. Another thing is you think about like the history of illness, and so like the age of onset, how bad functioning has been affected, family history of mental illness, so there's sort of various risk factors that might increase my suspicion for something.
Right. And I like that you kind of touched on like the spectrum of psychotic illnesses or of mental illnesses in general. That's kind of interesting. They're kind of like fluid diagnosis process. But so what is the process of diagnosis like for someone who's coming to a psychiatrist?
So yeah, it's a good question, and I think it's important to notice to know that when I see a patient, if it's in the hospital or if it's an outpatient, diagnosis is takes a while and is an ongoing thing. So I think the first time you meet with somebody, though, you have to be very comprehensive, and that's partly because, like I said, psychiatry is complicated, and you want to get a very full picture of everything that's going on. So I always start by trying to see if I have any collateral information, like if a patient comes in with a family member or a friend, or if they're referred from another physician. That's important, but it's helpful, but like the most important information is the interaction that I'm going to have with my patient. And then I just do a very comprehensive interview. And, an interview includes a lot of specific questions about symptoms, but it's also just a conversation and an interaction. And I think a skilled psychiatrist should be able to notice things like how the patient is engaging with me, their level of eye contact, if they're talking to themselves, if they're speaking, if I can't interrupt them, or if they're barely speaking at all, things like that. And then when they're speaking, their thought process, so how organized is what they're saying? Does it make sense? Is it logical? Does it seem that they're making up words, which some people do? And then what is the thought content? Is the person talking about being tracked by the CIA, and or are they talking about having millions and millions of dollars? And so those are, so all of that information kind of comes together. I also want to make sure I take into consideration a person's history. So their psychiatric history, have they been in hospitals before, that kind of thing? Have they taken medicines? Did medicines work? Their risk factors for have they attempted suicide. It's always important to assess risk for safety. And then also their medical history, because there are medical conditions that can have psychiatric manifestations or can interact. There's substance abuse history. There's substances that can create psychosis, and sometimes withdrawing from substances can look like psychotic or can be psychosis. So I sort of take all that takes a while to take all that information from somebody, and then kind of think about Other things are, family history of mental illness is important. It's, it's helpful to know, and illnesses do run in families, but if a person doesn't have a family history, that doesn't mean that they can't have an illness like that. And if they have it in their family, that doesn't mean they will have it. And then trauma history is important. And then sort of create physicians call it a differential. It's a list of all the things that could be going on with a person. So they might have a primary suspicion for something, and then they'll have a differential list of all the different things. And part of the initial plan is always like ways to figure out and clarify the differential and cross things off or bring things in.
Right. I mean, it sounds like a lot to consider and a lot to kind of be aware of.
Yeah,
it seems like a lot to handle. And so I know for me personally, when I was first speaking with a psychiatrist, it took a long time for like all those things to kind of come out, because there was a bit of mistrust and like just unease with the whole medical environment. And so does it usually play out over several appointments, or are you able to make a diagnosis on the first appointment, or how does that work?
No, I mean, I think it depends. I mean, I think there's like two settings, inpatient and outpatient, right? So sometimes, unfortunately, people get to a point where they become so ill that they have to be in the hospital. And then I think it's diagnosis can be faster, not just because they can have a longer interview, but because a person's being observed like 24 hours by other people. And there's time to sort of gather information. And also at that point, things are usually like really acute, really serious. So you see more things. So in the outpatient setting, it can take a while. Yeah, I've had, when I did outpatient work, sort of many appointments with people who were sort of the beginning to trust me and talk to me. And, it's definitely true that in psychiatry that we sometimes do treat people even though we haven't finalized a diagnosis, because if somebody is suffering and has distress from symptoms, then I still might treat them even if I don't know what I'm going to call their illness. And sometimes treatment can kind of be a part of the diagnostic tool, because if a person doesn't respond to stuff, I've had patients who had a lot of psychotic symptoms, but they had the label of schizophrenia before, and then they came when I saw them. They seemed very agitated and weren't sleeping, and I had my suspicions that they had a lot of mood symptoms. And so when they got a mood medicine, they got well, and that changed their diagnosis. So
right, okay, so it's kind of like an ever-evolving process for a lot of people.
Yeah.
So that can lead me to my next question too, of like, what sort of treatments do you provide or recommend for someone with a diagnosis of schizophrenia or schizoaffective disorder?
Well, so I'll tell you what I think should be provided to everyone, and with a caveat that it's not always provided in today's healthcare systems. Essentially, everybody with a psychotic diagnosis will take medication. I know that there's, and I want to just acknowledge that there are people who feel pretty strongly that they don't want to take a medication. And, I think if you have one of these diagnoses, it means that you meet a criteria that your functioning is impaired by your symptoms. And so that's why, so those people whose functioning is that impaired would all be prescribed medication. So antipsychotic medication is kind of the cornerstone of people who are experiencing psychosis. So that's, the sort of break with reality things, hallucinations, delusions, disorganization. The negative symptoms don't respond too well to medications. Um, um, but that's something that's being worked on pretty heavily. And along with antipsychotics, people with schizophrenia, schizoaffective disorder, other things related, they still can have a lot of other things going on with them. So people can have anxiety. People obviously with the affective, meaning the mood issues, will need mood medicines. So those different types of medicines for that. I do think that sometimes people forget that people with schizophrenia can get depressed and need and would benefit from antidepressant treatment. And then there's the psychosocial treatment, which is, I'm in favor of kind of a person-centered approach to the rest of treatment, which is all the other things that people need to achieve their goals. And, patients who get psychiatric rehabilitation treatment, either if they're in a community support team, that's sort of what we have in the US, ACT teams, or if they go somewhere, it generally is supposed to be around what are their goals and what are their issues. And so if their goal is to go back to work, then what do they need to do that? Some people need they might need social skills training. They might need help because they have negative symptoms or cognitive symptoms that are impacting their ability to do that. Some people have goals around, relationships and things like that. So I think there's a lot of different additional tools that are part of treatment. Generally, psychiatrists don't provide all of those, but they should and they often do refer or sort of collaborate, that kind of thing.
Yeah.
Hospital is similar, but it's just all together.
Right. The psychosocial aspect, I think, is something that is often overlooked in terms of what the healthcare system is like here in Canada. I think it's kind of overlooked in a lot of places where the focus is on really the medical model and medication, which is really important, like you said, the cornerstone of treatment. But there's also so much more to consider, and so it's nice hearing you talk about that and knowing that that is a consideration for psychiatrists as well, even though it doesn't always get facilitated the way that the current healthcare system is set up.
Yeah. I think psychiatrists like to think if we find a medication plan, then we can do all these other things. But I think, it's also just as people are getting well, and even if they still have symptoms, they like to hear about the other things because it can be a long road.
Yeah. So you also mentioned that negative symptoms are often very hard to treat with medication. So what kind of treatment do you recommend or do you provide for the negative symptoms, or is there any treatment?
It's a lot of sort of individual studies. I think there's some discussion in psychiatry about the line between negative symptoms and depression. When I trained, it was negative symptoms they're considered to be distinct from depression. And depression is supposed to be, a person's mood is affected. They might feel hopeless, pessimistic, think about suicide, whereas a person with negative symptoms just sort of lacks the motivation, may not feel anything at all. And so I think some of the treatment has been around treatment for depression in terms of medications. That's what I've seen a lot of. I've heard there's some evidence that there's one medicine in particular, I won't name medicines, but it's a little bit different than the other ones and requires frequent blood tests and stuff. And so there's some evidence that people who respond to that might also have improvement of negative symptoms. And then I think on the psychosocial, a lot of times it's a lot of family stuff, because it's a lot of like how the negative symptoms are impacting all the people around the patient, and sort of educating family as well. I think when families don't know about this stuff, they can misinterpret negative symptoms, and they can think a person's lazy, and a lot of times people will be not taking care of themselves, and that's just not understood. And there's a belief that then the person with negative symptoms just is reacting to a very negative reaction, and already has trouble, communicating, and it's just kind of like a cascade. So those are some of the things, but I'm really hopeful that there's some future research around like totally different kind of medicine for that kind of symptom.
Yeah. I think it's interesting too that you mentioned kind of like the component around education and advocacy that you also provide as a psychiatrist in terms of advocating for your patient with their family or with, other members they interact with. And so that's really great to hear too. The next question I have for you is that, I think a lot of people are afraid of like judgment when they're experiencing symptoms. And so I think a lot of people are afraid to kind of open up to a psychiatrist or a medical professional because they're afraid of judgment or whatnot for their symptoms. So I just wanted to kind of ask you, what are you thinking when someone comes to you with symptoms of schizophrenia and schizoaffective disorder?
I'm definitely not judging them. I can't speak for everybody, but I think, part of the reason people would assume that they would be judged is because they might have some awareness that they're experiencing things that are, unusual, that other people don't experience, that kind of thing. And they may have been judged by people around them who are not understanding. But, psychiatrists choose psychiatry because they're interested in solving these kind of problems and working with these kinds of patients. And also by the time, any psychiatrist is practicing, they have seen a lot of patients, including a lot with psychotic illness. Almost everybody in the United States who trains in psychiatry spends quite a lot of time in hospitals. And so it's like, I don't think there's judgment because I don't think it's an unknown thing to them. It's a known entity. It's a brain disease. I've never heard a colleague judge a patient for having a hallucination or something. I think what people talk about and why there's tension between doctors and patients in psychiatry is more like around this medication issue and all the complexities around that, which happens over time. But going to a doctor and saying, I feel like people are coming after me. I would not expect a psychiatrist to judge or to laugh at somebody like that, or we really do feel like it's kind of what we do.
Yeah, so I think like a lot of people who are experiencing these symptoms for the first time, it's very like outside of the norm for them. Like these things aren't talked about a lot within society, and so it's easy to kind of fall into the mindset of like, this is not normal, and so people are going to judge me and whatnot. And so I think they bring that along when they're talking to a psychiatrist. But it's really good to hear that like, no, this is kind of the norm in which psychiatrists operate within, and they're not judging. They're there to help the person regain a sense of normalcy within their life.
Yeah.
So kind of going along with the patient relationship and interaction in general, how would you recommend for a patient to prepare for an appointment with a psychiatrist?
Yeah, it's a really good question. And I think it's important to know that psychiatry appointments generally are, especially on an outpatient basis, are short. And so there's like this time pressure. And I think it's important for patients to know that psychiatrists have a massive amount of documentation, sadly, that they're saddled with. And when the patient comes in to see them, they have to make sure the patient is safe, not wanting to harm themselves, but also not wanting to harm other people, because people, sometimes people do get agitated because of their symptoms or whatever, and then there's all of that complexity. So those are sort of like things that they think about, and then medicines, whatever they're prescribing, has to be safe. And so I think the focus is often on that right off the bat. But after, there's time to bring up things that are bothering you. And I think the best way to do that is to just make a list before you go of what's bothering you. And the more specific you can be, the better. So if it's like, I'm worried about my sleep. I wake up every night in the middle of the night and I'm worrying about things and I can't get back to sleep and I'm only sleeping 6 hours, whatever it is. Or like I feel I can't go to the store because I feel like people are talking about me, and you said they're not, but I don't know how to check, or just something specific. So you have your things written down, and most doctors would be so glad to get that because it helps focus the conversation. If you have a hard time bringing them up, which some people do, then it's perfectly okay to just hand that to your doctor and say, I wrote down things. I think it's important to ask questions. Like sometimes doctors, might assume that patients understand things, and then down the road, if there's any kind of miscommunication between you and your physician, and then you start to have problems, whatever they may be, it's just going to be so much harder. And I think it's hard to be honest when you're talking about stuff. I think people are afraid of being put in the hospital sometimes. And so that's a hard one. But I think the earlier you kind of bring things up, the better, because then you can work on stuff together.
Yeah. That's definitely like a huge fear of mine, or it was a fear of mine when I was first building a relationship with my psychiatrist, of being put into a hospital against my will. And so I think that I would keep things from them in an effort for that not to happen. But what I kind of learned over time was that kind of perpetuated the need to end up in hospital, because I wasn't working collaboratively with my psychiatrist in terms of addressing the symptoms as early as possible. And so I kind of learned working with them that the earlier I'm honest with them, the less chance there is of ending up in hospital, because, he's explained to me that he doesn't want me to end up in hospital either. He knows it's been a traumatic experience for me. And so he wants to work with me to keep me out of the hospital. So that was a really kind of breakthrough moment for me in terms of understanding that psychiatrists want to work with you to keep you healthy and out of the hospital. And so it's good to hear from you in terms of early intervention and that kind of thing. And then that was also great advice in terms of asking questions if there's something you don't understand. And then I also really liked the piece of advice around keeping a journal or some kind of documentation around symptoms that you're experiencing, because it is kind of hard to recall those things in a quick opinion with a psychiatrist. That feels very pressured. And
it can be stressful, I think.
Yeah.
It's much easier when you're at home and or you maybe could even talk to your partner or something about it, and just kind of get it down on paper, and whether it ends up being something you bring up or not, you have it on your list.
Yeah.
I also think people should, if you're having a problem with your medicine, you have to bring it up. I mean, it's so much better if you bring it up than if you just stop the medicine or change it. I mean, again, your doctor doesn't want, they want you to do well. So if you just are look, I can't get out of bed with this medicine, what are we doing? And then sometimes there's solutions where people don't even know, taking a medicine a couple hours earlier, can change the way it affects you the next day. So just bring things up.
Yeah, open communication with your doctor.
And I do think everybody, I just want to say, should, try to have like a wellness plan. I mean, there's some out there, official ones that you can buy, but, it's just like when you're doing well, write down how you're doing, like what it looks like when you're doing well, and what it looks like when you're starting to not do as well, and what you want people to know when you're not able to communicate as well, and that kind of stuff. And you can share that with your physician, and they can take a copy of it. I think people would be surprised at how much psychiatrists would love this stuff. It's just that sometimes there's not a chance for them to ask for it, and I don't mean to say that it has to be on the patient to kind of build the relationship and stuff, but the more you share about yourself, the better able they are to help you, I think.
Yeah, great. Well, thank you so much, Monica. This was really, really great. I think you did a really wonderful job of kind of breaking down some of the barriers and some of the, mystification around psychiatry and around the psychiatrist-patient relationship. So thank you so much for coming and talking with us today. It was really great.
Yeah, this was really fun. Thank you very much.
Yeah. So, so again, this is Monica Slubicki, and thank you so much. She's a psychiatrist based out of the United States. So everything we kind of talked about was based in the United States, but I think it's very applicable to any psychiatrist-patient relationship. I think that you did a really good job of just kind of laying a general overview about what the process of making a diagnosis of schizophrenia, schizoaffective disorder is like, and what to kind of expect in terms of your relationship with your psychiatrist. So thank you so much again, Monica. That was really wonderful. Thanks for joining us today.
Well, my pleasure. Bye.
Okay. Bye. Take care.
So a really huge thank you once again to Monica for joining us and for sharing her valuable insights and experiences as a psychiatrist treating people who are living with schizophrenia or schizoaffective disorder. I know I learned so much from her in this interview, and I hope you all did too. And also, just a quick note that Monica reached out to us after the interview to mention that she really wanted to reiterate the importance of therapy. She felt she didn't cover it enough in the interview, and so she wanted to again reiterate that therapy is a really important process in treating schizophrenia and schizoaffective disorder. She also mentioned things being important like sleep, nutrition, activity, and all that kind of stuff, which I think falls under the umbrella of what she was talking about with the psychosocial components of treatment, but she just wanted to reiterate that. So I'm just conveying that she reached out to emphasize that. So I hope you found this video insightful as well or enjoyed it, and if you did, please make sure to like it and also make sure to subscribe so as not to miss any future content like this one. Also, just a quick reminder that if you want to help support the creation of future videos like this one, please make sure to check out our Patreon page. The link is in the description below. Thank you so much again for watching, and as always, wishing you and your loved ones good health. See you in the next video. Bye.